Hello again, everybody. We are going to spend this lecture talking about the orthopedic problems that encounter the proximal upper extremity. So I included the shoulder here, even though the shoulder may be considered part of the thorax because it involves the scapula, but it does involve the head of the humerus, so I figured I would include it in here just for simplicity. So we'll talk about some of the dislocations of the shoulder, namely anterior and posterior. There is an inferior dislocation of the shoulder, but it's incredibly rare, and I would imagine it would not ever come up on the USMLE. But just to let you know. And then we'll talk about 4 different fractures of the humerus, 2 of which occur both in adults and children, and the other 2 which primarily only are encountered in the pediatric population. So this demands a little bit of anatomy review, since anything with orthopedics, when we're talking about fractures or dislocations, some of the symptoms or the complications often involve neurovascular structures. So we should definitely have a good grasp of the local anatomy. So starting off with the humerus, the head of the humerus is the most proximal part, and of course that inserts into the glenoid fossa, which is part of the scapula, and together that makes up the glenohumeral joint. And so the glenohumeral joint is our shoulder joint, and around that are our muscles that are responsible for arm abduction, and that is our rotator cuff. So if you go down the diaphysis of the humerus, you see the radial groove, and the radial groove is going to be important because it also serves to remind you that the radial nerve travels very intimately with the humerus. The radial nerve is right next to the bone as it travels down, and the radial nerve travels posteriorly and then anteriorly as it moves distal. So it kind of wraps around the humerus. As you progress down distally, you have the medial epicondyle and the lateral epicondyle. We're going to talk about a medial epicondylar fracture, which is going to be really, really important. You see that in pediatrics. The medial epicondyle and lateral epicondyle will communicate respectively with the ulna and the radius. And the medial epicondyle is one of the attachment point for pronator teres and the wrist flexor muscles. So the humerus here, and this is looking from a posterior aspect. And the nerves of the upper arm, so they all come off of the brachial plexus, and I wouldn't worry about the musculocutaneous or thoracodorsal for our purposes here. Primarily, we're going to be focused on the radial, median, and ulnar nerves, which are the nerves that supply the forearm and hand. And we're also going to be concerned with the axillary nerve, which is seen up here, but it's not labeled. And the axillary nerve supplies, again, those the deltoid as well as muscles of the rotator cuff and some sensory innervation of the upper arm. So this is a sort of a zoom in of that picture. So I highlighted here the axillary nerve. The dotted line just means it's behind that bone. And here in pink, purple, we have the axillary nerve. And in green here, we have the radial nerve. And so make sure and remember that the radial nerve kind of travels down posteriorly and sort of wraps around the humerus. And then we have the median and ulnar nerves, which kind of travel down in the forearm like this. Okay. And then important to note the surgical head, which is part of the it's really just an imaginary line, but it's part of the humerus. What it is, the surgical head technically is it's the part right below where the physis used to be in adults. So the physis, remember, is the growth plate, and when that physis closes off, then it's no longer a growth plate, but the area right distal to the physis where it used to be is called the surgical head, and the surgical head is the most weak part, the weakest part of the humerus, and so it is at risk for fracture. And indeed, a fracture of the surgical head, which we'll talk about, is the third most common fracture in the elderly population. And then just to look at the vasculature of the arm, so we have the subclavian artery, which then becomes the axillary artery, and ultimately the brachial artery. And right around the elbow, the brachial artery bifurcates into the radial and ulnar artery. I would just, for our purpose, we're mostly going to be concerned with the brachial artery and then the radial and ulnar artery. Don't concern yourself too much with the deep specifics of the anatomy, but do know that the brachial artery travels in the upper arm. That's pretty basic. All right, let's look into some of the things that can go wrong. So first, we're going to start out with two different dislocations of the shoulder. The first being by far the most common. This is the anterior dislocation of the shoulder, and any dislocation of the shoulder is going to be a dislocation of the humerus, the head of the humerus, from the glenoid cavity. And the glenoid cavity is the part of the scapula that receives the head of the humerus. So this is the most common dislocation, and frequently you see this in younger patients, and the reason is because in order to get a dislocation of the shoulder, the ligaments have to have a good amount of give to them, or you have to have enough trauma to force the shoulder into that position. And remember, in younger patients, they have a greater degree of ligamentous laxity. Their ligaments are not as tight as in older patients. So younger patients who are playing sports where they can get themselves into acute trauma, think basketball players, football players, etc., that's the perfect storm for anterior dislocation. So, like I said, usually you see this in sports, but really anyone with acute trauma. Now, history of a prior dislocation is a big risk factor, and the reason for that is because when you have a dislocation of the shoulder, as mentioned, the ligaments have to have some kind of give. There's going to be some injury to the ligament. And when there's injury to the ligament, when it heals, it doesn't heal quite as strongly as it was before. And so because the ligaments aren't quite as strong after the first dislocation, once it heals, it's weaker, and so then it's easier to get another dislocation. So the more dislocations you get, the easier it's going to be to get more dislocations in the future, because when the ligaments heal, they don't heal as strongly as they initially were before the dislocation happened. All right, so what do we see when we see patients with dislocation of the shoulder? Well, always they're going to be in pain. They're going to be in some kind of going to be focused on their shoulder. Usually they're going to hold their arm in an abducted and slightly externally rotated position, and the USMLE will tell you this. However, in real life, what you more so see, what is most telling of the anterior dislocation, is that the head of the humerus is very prominent. It pokes right out at you, and you note asymmetry. The unaffected shoulder doesn't look nearly the same as the affected shoulder. So the humeral head is going to be prominent, and the reason for that is you have an anterior dislocation, so it's going to be popping right out at you since it's facing out anteriorly. It's not in the glenoid cavity. And then you're going to note asymmetry for that exact reason, because the shoulder is pointed outwards, pointed towards you anteriorly, if you're looking at them head on. And then the shoulder range of motion is going to be decreased, and that's for two reasons: because the humeral head is not where it's supposed to be, and you don't have a rotator cuff that's functioning properly, and because the patient is in a significant amount of pain. It's going to be really important to assess the neurovascular status, particularly focusing on the neuro status. So we're looking at the axillary nerve. Here, the axillary nerve runs right around the shoulder area. And what we're looking for here is not so much muscle function, but for cutaneous damage. And so you're going to be checking for numbness over the regimental patch. and that's the skin over the proximental arm. And that gets its name from the patches that military men wear on their shoulders. So it's a skin over the proximal arm. And of course, you're also going to be checking the radial pulse, just because the brachial artery runs in that area too. But particularly, it's important to document these things, because when you go to relocate the shoulder to externally reduce the shoulder back into its normal position, if the patient were to come back and say, "Doc, I've got this numbness on my shoulder," you want to be able to show that the numbness had already been there and that you didn't do it because of your treatment. Because you can get sued for various things. So you want to make sure that you're assessing this for medical legal purposes as well. So for diagnosis, usually the anterior dislocation is very obvious. The clinical picture, the history, physical exam. So not all the times in real life do you see x-rays being done. However, on the USMLE, you should assume that you do need to do an x-ray to diagnose anterior dislocation. And the best initial diagnostic step is an x-ray of the shoulder, so that's pretty obvious. You're going to need to get this in at least 2 orthogonal directions to diagnose it, because if you just get an anterior-posterior x-ray, it's hard to see that the shoulder is dislocated, because it's dislocated in the anterior position. So you want to get it from that direction and from the lateral direction, where you can see an anterior-posterior axis. So at least 2 orthogonal directions, and that's going to pretty much go for everything in orthopedic injuries. So here's the regimental patch where it gets its name from. And you can see these patches here are right around where that axillary distribution is. So right here. Believe it or not, some of the major ones here are really, really, really good to know. Definitely your median, ulnar, and axillary nerve, as well as probably your radial nerve, all good to know by heart for USMLE and for real life. I'd also include probably the supraclavicular nerve as well. So I would know those at least for the test. Okay, so this is kind of how a patient would appear. What jumps out at you is not so much how the patient is holding their arm, but the asymmetry. And this is just an illustration, but we'll see an example. You can see that there's 2 angles over the shoulder, and that's because that there's 2 shoulders, basically. There's the shoulder that's comprised of your scapula, which would be back here, and there's the shoulder that's composed of your humeral head, and that's right here. So there's 2 angles over the shoulder, whereas in the normal arm, the humeral head and the scapula are in communication with each other. Okay, so here's an anterior dislocation, and it's quite obvious that it's on the right side. So here's your humeral head that's very prominent from the anterior side. And if you were to draw a line over the arm, you get just one axis, just one uninterrupted line on the left side, the unaffected side. But if you were to draw it through the on the right side, you get an interrupted line. So that's another way you can clinically tell. So here's a normal shoulder x-ray. Remember the nice communication, nice parallel communication between the humeral head and the glenoid fossa. Here's an anterior dislocation. So this is a really bad one. They're not always this obvious. This is totally located out. The humeral head is totally located outside of the glenoid fossa. Here's another one, really bad one. I'm picking the really bad ones to show you first. Yeah, so there's the empty glenoid and the position of the humerus. So the treatment is going to be closed reduction of the glenohumeral joint. This can usually be done by an emergency practitioner, by an internist, You don't need to go to an orthopedic surgeon for this. And then you're going to have immobilization with a sling for 3 weeks. And the reason that we do that is, remember that the ligaments are damaged and we want them to heal in the proper position so that when they're healed, they're firm in the position that they're supposed to be in and not in some abnormal position. So it both reduces pain and it helps with proper healing of the ligaments. And NSAIDs can be used for pain during this time. However, if there's continued pain after 3 weeks, you should obtain x-rays again and consider that you may have possibly not properly reduced the joint. Now, a posterior dislocation is very similar to the anterior dislocation, but the only difference is that it's in the posterior direction instead of the anterior direction. So this is a posterior dislocation of the head of the humerus from the glenoid cavity. This is extremely rare. It makes up only about 1 to 5% of the dislocations. And generally, this is a result not of injury, but of discoordinated muscle contractions of that rotator cuff. When would we have discoordinated contractions? Most commonly in seizures. Seizures, of course, are, if you have of course, we're talking about tonic-clonic grand mal seizures here, but that, of course, can cause this discoordinated muscle contraction. You also may see it in patients who have electric shock because, again, they can have this discoordinated muscle contraction. So I would remember that for a vignette, that in the cases where you have a posterior dislocation, it would be electric shock or seizure. So you have a patient who's got a history of having a seizure, suddenly now they've got shoulder pain. Think of posterior dislocation. The diagnosis is going to be the same as how we do the anterior dislocation diagnosis. It's going to be shoulder x-rays, but often this gets diagnosed because a lot of clinicians just order the AP x-ray and they don't remember to get 2 or preferably 3 directions. And if you just get one direction, it may look normal. So you're going to need to get the 2 or 3 directions on your x-ray in order to diagnose the posterior dislocation. So this is often undiagnosed, and it's really important. Again, this is why I stress, make sure you get 2 or 3 directions on your x-ray if you have shoulder pain. And really with any kind of fracture or orthopedic problem, you want to have 2 or 3 directions on your x-ray. It's never sufficient to have only one. And the treatment here, again, the same as anterior dislocation, it's just going to be the external reduction and immobilization. Okay, so let's talk about some fractures of the humerus here. So now we're talking about bone breaks or bone fractures. First one we're going to talk about is the surgical neck fracture, and that again is just that area that surgical neck is not anything anatomically, nothing that you would notice on the humerus. It's not any line, it's just an imaginary line. But what it is it's the portion of the bone just distal to the growth plate or where the growth plate was in an adult. And then the second fracture we'll talk about will be the mid-shaft fracture, and that's just a fracture of the diaphysis anywhere along the humerus. The third fracture we'll talk about will be the supracondylar fracture, which I talked about in the pediatric fracture section. This is a very common thing to see in kids because of their ligamental laxity. And then finally, we'll talk about the medial epicondyle fracture, which is an avulsion fracture. All right. So anytime you approach fractures, the diagnosis is always going to be by x-ray. Generally, the symptoms are going to be pain, localized pain, swelling, possibly ecchymoses, depending on how much vasculature is around that fracture or how bad the vasculature was damaged. It's important, as I mentioned a couple times already, to get multiple dimensions when you do the x-ray, so at least in the x and y or x and z directions. And so at least 2 or preferably 3 directions. Remember that the anatomy is really important. So anytime you're considering orthopedic problems, you need to consider the anatomy. Even if it means in real life going back and looking up, pulling out your old rusty netters and looking up the anatomy around the area, you should definitely do so because we're always concerned about nerve or vasculature damage or compromisation around the area of the fracture. So fractures are a lot of times accompanied by nerve palsies, which can either be manifested as motor weakness or as numbness due to sensory palsy. And then the treatment for fractures can usually be accomplished with closed reduction and casting, but this is going to depend on the severity. In some cases, you will need open reduction with internal fixation. In more complicated cases, especially when the fracture is open, or if there's multiple bone fragments, like a comminuted fracture, or if there's vascular damage, just because you're going to need a vascular surgeon to go in there and repair the damaged vessel. Okay, so we're going to first talk about the surgical neck fracture. And I'm just denoting here that it's the surgical neck of the humerus, because we also have a surgical neck of the femur. And so this is a surgical neck fracture. You can see it's right where the diaphysis starts. That's approximately your surgical neck. Usually these are going to be transverse fractures. And this is what that is right here. So a surgical neck fracture is a fracture of the surgical neck, as mentioned. That's part of the part of the humerus that's just distal to the former physis. And I note former here because usually this is a fracture that happens in adults. So the growth plate will already be calcified. Usually the cause here is direct trauma, so we would see this. There's a bimodal distribution of the surgical neck fracture and of the midshaft fracture. And it's bimodal because we see a lot of times in kids, this is a result from trauma, from athletics, from sports injury. And then we see it in older adults because of osteoporosis, because their bones are weaker, just because of that pathology. And this is the third most common fracture in the elderly, so it's definitely something to remember anytime you have a patient with osteoporosis who falls and then has arm pain, that a surgical neck fracture is something that is definitely something to consider because this is so common. Now the symptoms here are going to be pain, swelling, and decreased range of motion, and that's just typical for most fractures. But what you will see here that you don't see in a lot of fractures are ecchymoses of the upper arm and chest, and that's not necessarily something you see in everybody, but because the vasculature over the head of the humerus is so prolific and rich, if you damage that vasculature, and a lot of times you do, you can get bleeding then into the skin, which would then be ecchymosis. For diagnosis, as with all fractures, the best initial diagnostic step is going to be an upper arm x-ray or an x-ray wherever the pain and swelling is. And we're going to want to get that in at least 2 or preferably 3 directions. And that would be anterior, posterior, the Y x-ray. And the Y x-ray is just looking from overhead down. And then a lateral x-ray. So we're making sure we cover all 3 directions. But usually 2 directions is enough, but 3 directions is the best. You're going to want to assess the neurovascular status here, and that's going to be true for all of these fractures. Most commonly here, and this is where it's going to be important to remember the anatomy, with the surgical neck fracture, what is the nerve that's up there at the top of the shoulder? It's going to be the axillary nerve. So when the axillary nerve is affected, we have to remember what are the things that the axillary nerve does? Well, it supplies motor input to the rotator cuff muscles and the abductor muscles, shoulder abduction, and it also applies sensory innervation over that regimental patch. So you're going to want to check both arm abduction and you're going to want to check over that the skin over the proximal arm. And this is going to be really important just because you want to know if you're going to want to document this before you do your treatment. Another thing you want to do is check the radial pulse. And most of the time the radial pulse will be present. You only need to check the radial pulse here because the only vessel that can be damaged is the brachial artery or the brachial artery, I would say. But you want to check for that just to make sure that there's no vascular damage going on. Most of the time, this won't happen just because all of the vessels around the shoulder will make up for any kind of damage that's already there. But definitely make sure that you check for the radial pulse. Treatment is going to, as always, depend on fracture severity and the degree of displacement. Usually we can do this with closed reduction and splinting, but in some cases open reduction with internal fixation will be necessary. So here's another surgical neck fracture. And here's another one. So you notice that this one's only slight, but this one's a lot more. Okay. And then here's another one. Okay, so the mid-shaft fracture is a fracture of the diaphysis of the humerus, and this can be transverse, it can be oblique, or it can be a spiral fracture. So it's a fracture of the diaphysis of the humerus. Usually the cause is direct trauma. Again, this is another one that you can see in osteoporosis, and you can see in younger kids or adults who are involved with sports and athletics. The symptoms, like most fractures, are pain, swelling, and decreased range of motion. As far as diagnosing this here, again, the best initial diagnostic step is the upper arm x-ray, the x-ray right over the area that's affected, and we're going to want to get at least 2 or preferably 3 directions. Hopefully I'm cementing this into your head. Again, we want to assess the neurovascular status. However, what is the nerve that is traveling around the humerus that would be most likely to be affected by this midshaft fracture? Remember the radial groove? The radial nerve travels very, very, very closely and intimately with the humerus. And so, anytime you get a midshaft fracture, the radial nerve is what we are concerned about. So the radial nerve supplies motor innervation to the wrist extensors, and it supplies sensory innervation to the dorsum of the hand, more particularly the lateral dorsum of the hand. So we want to check there, and of course we're also going to want to check the vascular status as well, so you can do that by checking your radial pulses. And the treatment is going to, again, depend on the fracture severity and the degree of displacement. Most of the time, I would say 80 to 90% of the time, we are going to be able to treat this with simply closed reduction and splinting. However, sometimes in the more complicated cases, we will need to do open surgery. So here's another mid-shaft fracture. This one's pretty close to being open. You can see here, this is the skin. And then here's another one. This is a spiral fracture. And if you haven't watched my lecture on fracture types, I recommend doing so. If you were to see this in a little kid, like 6 years old, and the parent said, my kid broke his arm because he fell down off of the couch or fell down the stairs, probably not, because this is a fracture that comes with torsion and twisting of the arm. And so we're concerned with child abuse there. And here's another one. This would probably need open reduction and internal fixation, because as you can see here, the bone, the humerus is in 3 pieces. And so this is going to be a very difficult, this would be a very difficult fracture to reduce externally, just because you have multiple pieces. Okay, the supracondylar fracture of the humerus. Now this is a fracture that tends to happen in children. And the reason, well, let's just first take a quick look at it. So this is a distal fracture because it's just right above the condyles. And the reason that this has a tendency to happen in children is because this is a fall with a hyperextended arm. That's what causes this. And now who can hyperextend their arm? It's kids. Kids can hyperextend their arm because they have increased ligamentous laxity, because their ligaments aren't fully developed yet. And so we tend to see this in younger kids. If they fall down, they can, we all extend our arms when we fall down. That's our natural reflex. But kids, if they rapidly extend their arm, they can actually hyperextend it because they don't have the ligaments to keep their arm from hyperextending. I mean, they have the ligaments, but they're not fully developed to keep the arm, the elbow, from hyperextending. And so if you have that hyperextension, when you fall down, you're at risk for the supracondylar fracture. So we really only see this in children because you need that hyperextension of the arm to cause this. So usually this is in grade school age children. The symptoms here, again, are going to be pain, swelling, and kids are going to be very, very mad if you try to touch them. They're going to hold their arm very close to them because it's the most comfortable spot. And a lot of times you're going to see an abnormal neurovascular exam. Why? Remember, this is a fracture right around the elbow. And if you look at your own elbow as compared to your shoulder or the rest of your arm, your elbow area is a pretty narrow space. And remember that median nerve, the ulnar nerve, the radial nerve, the brachial artery, which is likely by that point bifurcated into the ulnar and radial artery, they all travel through there. And it's such a narrow little column that they travel through that if you get a fracture in that area, all of those structures are at very high risk. So we definitely need to make sure that we're checking for neurovascular complications, really in all fractures, but especially in this fracture, just because all of those structures are so close to where this fracture can happen. So we want to make sure that we're checking the brachial artery, or by this point it may have already bifurcated to the ulnar and radial artery, and we want to check the three major nerves of the forearm, the radial nerve, ulnar nerve, and medial nerve. On physical exam, often there's going to be swelling present right around the elbow. And like I said, the physical exam should be focused on detecting the neurovascular complications. So we want to check the distal pulses, and we want to make sure in this case that we check both the radial pulses and the ulnar pulses, because you may have damage to the radial pulse or to the radial artery, but not the ulnar artery, or vice versa. Unlike the more proximal injuries to the humerus, where because you only have the brachial artery up there, you would always, if you have damage there, you would always have reduced pulses at both the ulnar and the radial artery. Here, it could be one and not the other. So you want to make sure that you're checking both. And you should also watch for swelling. And swelling is a big problem because it indicates possibly compartment syndrome, which is a major complication of the supracondylar fracture of the humerus. And that's one of the things that makes it relatively unique among these fractures that we're talking about. And then, of course, checking for numbness of the hand, because any three of these major nerves can be affected. And the radial, ulnar, and median nerve all supply sensory innervation to the hand. Remember, the ulnar nerve is the more medial hand, the pinky and the ring finger. Radial nerve is more of the dorsum of the hand, and then the median nerve is the lateral hand, the thumb and the pointer finger and the middle finger. As far as diagnosis, you've probably predicted by now the best initial step is going to be an X-ray, at least two directions, and if the distal pulses are ever lost, either at the radial or ulnar artery, we want to order an emergent arteriogram, because the surgeon is going to need to repair the damaged artery, and we want to know exactly where the problem is so that the surgeon knows ahead of time. So, how do we treat this? Well, as I mentioned, if there's vascular compromise, we want to get an arteriogram, and then this will have to be followed by an open reduction and internal fixation, as well as repair of the damaged artery, and then this will be followed up by casting. If there's no vascular compromise, then we'll be able to treat this just simply with closed reduction and casting in most cases. As mentioned, watch closely for complications, particularly compartment syndrome. You can get compartment syndrome from a lot of different things, rhabdomyolysis among other causes, but here we would have compartment syndrome. We would have the exact same symptoms we would see from any other cause: tightness of the compartment, tenderness to palpation, discoloration, turn like a reddish or purplish color, and pain on passive motion. And then this is just due to loss of the circulation or to rapid reperfusion. And the problem is that if you have compartment syndrome and if it's not treated properly or timely enough, it can lead to a Volkmann contracture. And the Volkmann contracture is sort of like a claw, almost looks like a claw hand position. I don't have a picture of it here. I think if you go back to my pediatric fracture lecture, I do have a Volkmann contracture picture on that one. But any compartment syndrome warrants emergent fasciotomy. And a fasciotomy is just simply cutting an incision down the forearm, and that will relieve the pressure and reduce the damage that can do to the muscles, because it's really the pressure that damages all the structures when you have compartment syndrome. Okay, so important to remember the treatment for supracondylar fracture and the possibility of compartment syndrome. So here's another supracondylar fracture. This is probably going to, no matter what, require open reduction, internal fixation. Why? This is an open fracture. You can see the tip of this bone, and it's going past the skin, or really, really close. This is not going to be able to be externally fixated. Alright, and then this is another one. Again, this one's pretty severe. Okay, so medial epicondyle fractures. This is the last one we're going to talk about. And a medial epicondyle fracture is simply an avulsion fracture of the medial epicondyle. Now this looks relatively non-severe, and it kind of is. This one isn't going to present the same way as the other ones. The other ones, the patient's in severe pain, they're swelling, etc., etc. They're going to present right away. This one is a little bit more, a little bit less dramatic. And the reason is, well, it's not a really big fracture. It's just a little bit torn off. But this is still important because the medial epicondyle is the attachment place for the wrist flexor muscles. Remember, flexor carpi ulnaris, flexor carpi radialis, flexor digitorum longus, etc., as well as pronator teres. So with a medial epicondyle fracture, it's an avulsion fracture of the medial epicondyle, as most epicondyle fractures are avulsion fractures. And avulsion fracture just simply means that it's a fracture because the ligaments have pulled on that epicondyle so much that it's actually torn the epicondyle away from the rest of the bone, in this case the humerus. And this has an increased incidence in children, roughly aged 9 through 14. And as I mentioned, the medial epicondyle is an insertion point for pronator teres as well as the wrist flexors. Now, most commonly, this is going to be caused from a fall on the outstretched arm, and you can imagine why. If you fall down on your arm, what's going to happen when you, as soon as you hit the ground, is that your wrist flexors are going to contract, and when your wrist flexors contract suddenly and violently, as they do in this case, then that can pull the medial epicondyle and tear it off of the humerus. Get that avulsion. You can also see it in athletes who throw things. So think of like pitchers in baseball, and you should really familiarize yourself with some of the American sports, because then you can kind of think of sort of some of the injuries that you might see in specific sports. But we commonly see this in baseball pitchers, young Little League baseball pitchers. Why? Because when they throw the ball, and they throw it as fast as they can, what are they doing? Well, they take the ball in their hand, and they're throwing it, and what do you do when you throw? Well, you're activating your wrist flexors, and you're activating it very quickly to throw the ball fast. So when you throw and you activate those wrist flexors and you do it in a very rapid way, that can cause the medial epicondyle fracture. So a lot of times on the vignette, you'll see a Little League pitcher who threw the ball, and now he's got tenderness over his medial elbow. So the symptoms here are not going to be as dramatic as what you would see in the other three fractures, and it makes sense because the fracture is not as significant. What you will notice is pain in the medial elbow. The patient will complain of that. And there'll be point tenderness over the medial epicondyle just because there's inflammation there. And what you also might see is an ulnar nerve palsy. The ulnar nerve travels very intimately through the medial or by the medial epicondyle. It's the one that travels most closely to the medial epicondyle. So when we have a medial epicondylar fracture, the nerve that's most likely to be affected from that is the ulnar nerve. And remember that the ulnar nerve is responsible for motor innervation for the wrist flexors, and it's also responsible for sensory innervation of the medial hand. So again, here we want to assess the, well, I should probably put for diagnosis, we're again going to diagnose this with plain film x-rays of the elbow. And then we want to assess the neurovascular status. Like I said, most commonly the ulnar nerve is going to be affected. And so a lot of times you'll see weakness of the flexor muscles, not just because the medial epicondyle is fractured, which of course is going to cause weakness just because the wrist flexor is attached there, but also because the ulnar nerve has a palsy, and so those muscles are going to be weak. Which you'll also notice in the case of an ulnar nerve palsy is the sensory loss to the medial hand. And the treatment here is going to, again, depend on fracture severity and the degree of displacement. It's usually almost always able to be treated by a closed reduction and splinting, but occasionally it will need to be treated by open reduction and internal fixation, and that's going to be, again, it's going to just depend on how far that medial epicondyle is torn away from the rest of the humerus. So here's a medial epicondyle fracture, very, very, very close to the humerus. This one will probably be able to be treated with closed reduction. And here's another one, and this one needed to be treated with open reduction and internal fixation with a screw to put that epicondyle back into place. So just to recap, we have our shoulder dislocations. Our shoulder dislocations, most commonly they're the anterior shoulder dislocation. Usually these patients will have a history of trauma, usually in sports, and ligamentous laxity is another possible cause, either if they've had a previous anterior shoulder dislocation, or just some patients have a congenital predisposition to shoulder dislocation. The symptoms we would expect here are shoulder pain, and we would see an anterior protrusion, which is the head of the humerus. And these patients tend to hold their arms in internal rotation and adduction, because that's the way that they get their head of the humerus as close to the glenoid cavity as they can. The nerve that's affected with the shoulder dislocations is the axillary nerve. So remember to keep in mind your regimental patch over the upper lateral arm, and then the arm abductors, shoulder abductors. And the way we treat anterior shoulder dislocation is with closed reduction and a sling, just for immobilization to let the ligaments heal. With posterior shoulder dislocation, we tend to see this in patients with a history of discoordinated muscle contractions, especially seizures. Symptoms here will be shoulder pain. This is sometimes a difficult one to diagnose because if you just get an AP x-ray, a lot of times it looks normal. Nerve here, again, axillary nerve. Anytime you have damage to the shoulder or upper humerus, you should be thinking axillary nerve. Treatment here, again, is going to be reduction. For the fractures, remember surgical neck fracture, generally due to direct trauma. Remember, it's the third most common fracture in the elderly. Symptoms here are going to be pain, swelling, decreased range of motion, and possibly ecchymoses just because of the rich vasculature around the humerus head. The nerve here, again, is going to be the axillary nerve, and this is treated with closed reduction and immobilization or open reduction and internal fixation. Mid-shaft fracture is also commonly caused from direct trauma, and it also presents with pain, swelling, and decreased range of motion. In this case, the nerve that's most commonly affected is the radial nerve, because remember, the radial nerve travels very closely to the humeral diaphysis, and so we would expect that if any nerve is going to be affected by a fracture of the humeral diaphysis, it will be the radial nerve. Again, Treatment is going to depend on severity. Usually it's treated with closed reduction and immobilization. Sometimes it will need open reduction with internal fixation. The supracondylar fracture is usually seen in kids. This is a fall on an outstretched hand with a hyperextended elbow. And the symptoms here, again, are going to be pain, swelling, and decreased range of motion. Really, any nerve can be damaged here. The treatment here will be to monitor, make sure that you're checking the pulses, and if you have any kind of loss of pulses, get an angiography, and that will also require open surgery. Otherwise, you can usually do closed reduction with immobilization in cases that aren't complicated. And then finally, the medial epicondylar fracture. The history is going to be a fall on an outstretched hand or some vigorous motion of the forearm flexors, so like overhand throwing. Again, this is something that's more commonly seen in kids. And the symptoms here are going to be a little bit less dramatic: medial elbow pain, tenderness right over the medial epicondyle. Remember that the medial epicondyle, that's your funny bone, so you kind of know where to press. And this will also cause a weakness of the wrist flexors, not only because the medial epicondyle is where the wrist flexors insert, but also because the ulnar nerve provides motor innervation to those wrist flexors. The ulnar nerve, as mentioned, is the nerve that will be damaged here. And this is treated either by closed reduction and immobilization or open reduction with internal fixation. And for diagnosis, for all of these, make sure you get x-rays in at least 2 dimensions, or preferably 3, in the region that is affected. And that is it.